The unilateral custom Endosteal implant. Again, the custom Endosteal implant is only used when all other measures are exhausted. You can't augment the bone, can't place root forms, whatever reason. Usually it's because you're impinging on the mandibular canal, or in the maxillary posterior, the sinus is too illuminated to place root forms. So the unilateral custom Endosteal is used as a last resort and used very successfully. The purpose of this presentation is to give you an idea what the unilateral custom Endosteal implant is used for. We'll go over in detail as to how to place various types of unilaterals and how to restore them as well. The beauty of the unilateral custom Endosteal implant is that when you run across situations in surgery after you flap back the tissue and the patient's expecting an implant, and you find an impossible situation that you know you can't split the ridge, you know you can't augment because basically your two cortical plates are fused together and there's no blood supply. The unilateral custom Endosteal allows you to just get the impression material out, take an impression, and continue on with this modality as if nothing happened. So it's a very valuable modality for full-time implant dentists. There are four basic, most used custom Endosteal implants: the maxillary posterior, the mandibular posterior, the maxillary anterior, and the single tooth. The maxillary unilateral is only used when the bone under the sinus is insufficient for root form placement, or root form placement when used concurrently with a bone augmentation. In other words, a maxillary unilateral is used when the bone thickness is under 3 millimeters, when a root form implant cannot be stabilized when done concurrently with a sinus augmentation. When the bone is very thin, 1 millimeter or so, the maxillary posterior may require a sinus augmentation to allow for notching. The procedure for the maxillary unilateral includes a direct bone impression, and then when the sinus bone is very, very thin, then a sinus augmentation procedure is completed and 4 or 5 millimeters of bone is added under the sinus. Then surgically close and wait for the implant to be constructed. When the implant is placed, in either case, whether it was a sinus augmentation or whether there was enough bone under the sinus, a notching procedure is used to place the implant. This is a case where we did a posterior maxillary custom Endosteal. We did a blade implant and several root forms, and we also did ridge splitting in this case. This custom Endosteal is done without crossover notches, and it was done several years ago. And I think when you see the photographs of the crown and bridge, that the best crown and bridge came off the custom Endosteal implant. This is the right side where we placed the custom Endosteal implant. After the tissue was healed and we placed the crown and bridge, it was at a relatively normal level. On the upper anterior and left side, we placed several implants after we had split the ridge. The final result was that we didn't get the bone regeneration around the ridge augmentation as we did around the custom Endosteal side. The aesthetic result is the teeth are all probably 3 to 4 millimeters longer than on the right side. In this case, the patient doesn't show her gum line when she smiles widely, and so it's purely academic as to where the gum line is located. However, there are many cases where the gum line does show, so that the gum line is important in many situations. When we evaluate for fixed teeth or removable, that upper gum line is very important. This is the case where we had a patient who had a custom Endosteal implant and a root form fail in the upper right posterior maxilla. So to mitigate this problem, we've decided to pull out all the stops, and we did sinus elevations, waited 6 months, and then had a custom Endosteal titanium implant made so that it could accommodate 2 root forms in between. This is a 3-week post-op check on this case, and we're planning on waiting 5 months for the root form implants to heal before we restore this case. The mandibular unilateral is used when insufficient bone exists above the mandibular nerve, less than 10 millimeters or so. Most cases can be notched. However, the bone cannot be notched if little bone exists over the mandibular nerve. The flap procedure for the mandibular unilateral. A mid-ridge incision through the thin fibrous band of connective tissue from the posterior retro-molar pad to the anterior teeth is performed. A posterior relieving incision through the retro-molar pad to the external ascending oblique ridge is then done. A full thickness flap to the muscle attachments is then completed. Do not reflect the muscle attachments. Flap over the external oblique ridge 4 to 5 millimeters. The mandibular unilateral custom endosteal implant is one of the most difficult procedures that I've found to photograph. What you see here is a reflection of a very thin mandibular ridge with a mirror. It's very difficult to see, but if you study it, you'll be able to see the very thin ridge. The ridge is directly in the center of the photograph, and it's probably about 8 millimeters from the buccal sulcus to the myohyoid line, and light reflecting right over the top of the ridge so that you can see the top of the ridge with very little connective tissue. The ridge is very carefully bisected with a number 15 scalpel, and care is taken to very carefully bisect down the middle of the little fibrous band of tissue from the retromolar pad to the anterior teeth. I'm reflecting the tissue with a number 6 waxing instrument. I found that this instrument is a very nice periosteal elevator because it's very small and very easy to manipulate. And I'm very carefully reflecting first the buccal flap and trying not to disturb the periosteum, and then I reflect the lingual flap to the myohyoid muscle down into the digastric area, and then I flap the buccal up over the external oblique ridge, and trying not to bisect or reflect any of the muscle attachments over the external oblique ridge. You can see the progress of the reflection through the mirror. You can now see the top of the mandibular ridge. We still haven't gotten over the external oblique ridge. You can now see in the mirror reflection the external oblique ridge. The next procedure is tying back the tissue. We use 2 to 3 sutures that tie back the buccal flap, and then we use a suture that ties back the lingual flap kind of in a purse string over to the occlusion on the opposite side of the ridge. I'm not showing this procedure, but you can go back to the DVD of the maxillary endosteal implant and review the tie back procedure if you want to review it. You can now see the tie back sutures, and now we're getting ready to place our gauze and then our final impression. The gauze helps extend the tissue for easier placement of the impression material, plus it aids in hemostasis. The impression procedure. Equal portions of retro-seal putty are mixed together using a twirling, twisting, and kneading procedure to incorporate the material into a homogeneous mixture. Small pieces are then taken and placed into the bony areas and kneaded together and molded into a nice solid impression over the bone.
Hand-me-roll pieces.
For these unilateral impressions, you need to build up the impression material so that when the patient bites down, there's a registration of the teeth in the bite. It is clearly evident that this material is built up so that when the patient bites down, we'll get a bite registration from the